Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
Hello, my name is Cully, and I'm on the marketing team at Axxess. In this video, Axxess clinical consultant Arlene Maxim and Executive Vice President David Merk will analyze the 2022 proposed Medicare payment rate changes, the potential impact, and how home health organizations can take action. Arlene has experience in all areas of patient care quality, analysis, and administrative functions in post-acute healthcare. She is a board member and vice chair for the Association for Home Care, Hospice Coding, and Compliance, and she has worked as a strategic consultant, public speaker, and trainer in the home care and hospice field on regulatory, operational, and survey compliance topics since 1986. With more than 40 years of nursing experience from direct patient care to management, Arlene previously co-founded regional multi-million-dollar Medicare-certified home health organizations, hospital-based home care and hospice companies, and transitional care programs. David Merk is the founder and CEO of Home Health Gold, which has been providing Medicare-certified agencies with extensive data analytics and OASIS scrubbing tools for over 20 years. Prior to launching Home Health Gold, he worked for 11 years as president and CEO of a large visiting nurses association in Central Maine. In March of 2018, David joined the management team at Axxess as part of the acquisition by Axxess of Home Health Gold. Thanks for speaking with us, Arlene and David.
Thank you, Cully. For the last several years, as the Medicare has proposed and then implemented PDGM, we have become used to a reimbursement system that has a lot of little complexities, but that is attempting to provide care, to encourage agencies to provide care to the patients most in need, those which are the target patients for CMS. Today, we will look at the proposed changes for 2022, including a detailed look at how case mix calculations are performed, and there are changes in those this year. And we will also look at the impact of those changes on selected patient groups. Finally, in the event that you wish to respond to CMS's proposed changes, Arlene will be providing information on how and why you might do so. Let me review the highlights of the draft rules. First of all, and we won't go into detail on this in this presentation, but first of all, the new rules provide for value-based purchasing for all states participating in Medicare. This means that individual agencies in all of states now have the opportunity to have either significantly more or significantly less reimbursement, depending on how their patients' outcomes scores are showing and depending on the patient satisfaction scores that they have under the CAPS program. As I say, this is a detailed, the VBP has a lot of aspects to it, and they'll be reviewed at another time. Basically, the other significant change under the rules is that there will be a 1.7 projected increase in payments. CMS expects that they will spend 1.7 more dollars on home-based Medicare services than they did in 2021. There will be no change in the LUPA adjustments. There'll be no change in the thresholds. LUPA thresholds became difficult under PDGM, and they will remain difficult, and agencies need to continue to look at ways to monitor that, to ensure that patients are getting the care that they need, and that it's and to avoid unnecessary unnecessary LUPAs. One of the other things about the rules is that they will retain the behavioral adjustments, the 4.6% reduction, the money that CMS held back because it believes that individual agencies may modify behaviors to increase payment. That whole practice stays unchanged. Overall, though, the same basic structure is going to be used. We've got 12 clinical groupings, 432 case mix categories, and those categories are based on the combinations of 5 determinants: admission source, timing, clinical grouping, functional deficits, and comorbidity. However, the critical thing is that there are shifts now in the case mix weights that might go along with particular combinations. And we'll get it, that's where we'll get into the detail. Let's start off with the standardized 30-day payment rate. That's part of the, there's always been a standardized rate that got modified in particular ways under the CMS payment systems for home health. It's on a 30-day basis now. And the base amount will shift from $1,901 to $2,013, which is an increase of 5.9%, which sounds great. However, remember, it's going to be offset by changes in the case mix because some categories are actually going to receive fewer dollars overall because their case mix has dropped significantly than was true in 2021. Again, we're talking about an increase of 1.7%. We start off, and we attempted earlier, and actually it's back in 2019, to show how the case mix varied depending on particular determinants and what kinds of things made a difference. And so we're going to start off by talking about the clinical group. There are 12 clinical groups, and if we assume a situation where there is a 1.0 wage index, if we assume that we're working with a late community payment period, that it has low functional and no comorbidity, we're looking at the lowest amount that could get paid for that 30 days. And so let's take a look at how that lowest amount varies from clinical group to clinical group. If you look at this table, you see juxtaposed the 2021 and the 2022 rules and the change levels. Just quickly here, the medication management, teaching, and assessment for endocrine is an area that is getting additional dollars and significant dollars, 17% increase. So it jumps from being the third to the second, from the fourth to the third highest category. MMTA surgical aftercare has increased, and wound, which has always had a fair amount of resource, has increased significantly. On the other hand, and you'll see this throughout here, complex, the complex clinical group, and I'm recognizing that there may be complex patients under all of the clinical groups, but the complex grouping itself has dropped, and it's dropped in most every particular. Let's take a look at the next factor that affects the case mix, and that is if we get to talking about anything other than a late community. Suppose we talk about a late but institution referral, or an early community or an early institution. Again, we see the dollars heavily prized for the heavily prized care of the referrals from institutions. And we see that those have gone up. More dollars proportionally have shifted to institutional care from other kinds of care, other kinds of referrals. The next level is functional. And as was true before, the functional amount varies by clinical group. So we have a combination of those two to determine what the rate is. And generally speaking, again, you can see the 2 years compared, but what's for both medium and high. But you see particular areas where the value has gone down. In the complex grouping, that level has gone down considerably. And what's even more interesting here, and it's kind of curious, is that if you have a higher functional level, high rather than medium, you'll get less than you would for the medium. I've never seen that before in these numbers, but that's definitely there in the numbers that have been released by CMS. I keep thinking that they may correct that at some point. In addition, we see that MMT, endocrine, and wound again they are highlighted, but for a different reason. They were the ones that increased the base amount the most, but they're actually losing dollars on the extent to which they have a functional add-on. MMTA surgical increased at the base amount, and it increases significantly here. The last add-on is for comorbidity. And again, you see increase in the dollar amounts and a significant increase, a jump from 275 per 30-day period to 446 per 30-day period for high comorbidity. And the calculation of comorbidity, or the determination of that, finding out what you would have for comorbidity, has become much more complicated. CMS increased greatly the number of different subgroups that play into comorbidity determination. But basically, overall, they expect a lot of comorbidity add-ons in 2022, and they have also have shifted so that those will be worth more money to agencies. If we put it all together and we look at the highest possible 30-day payment, it would be for a person who has wounds, is in the wound clinical grouping, early institutional, of course, high functional, high comorbidity. And that means that the total dollars in 2021 would be $3,432. Under 2022, it would be $3,866. And on the low end, we see that there's a slight difference in the lowest payment. That is the case where you get the clinical grouping value, but nothing else. Overall, there's a slightly wider range of payment levels. And we have winners and losers. And what I tried to do here was show the 5 top gainers and the 5 top losers. And you can see the significant dollars. And what you also notice is that all of the cases where the amount that will be paid in 2022 is less than 2021, all of those top cases are complex clinical grouping. And all of the ones where more will be paid in 2022 are the ones that we highlighted earlier, the wounds, the endocrine, and the surgical aftercare. I'm going to turn things over now to Arlene to talk about what some of this may mean in terms of how care is actually provided within an agency.
Well, thank you so much, David. That was incredible information about what we can expect next year. I want to talk a little bit about how all these numbers are going to affect us and what we need to do as agencies to overcome some of the challenges we're going to have. So as David mentioned, that a lot of this information that we have about the dollars that will be issued to us varies regionally, and it also varies by referral source. So depending on your wage index, that there will be a difference there. Smaller agencies are going to struggle more than the larger agencies. And as you all know, we have medical reviews coming up and that type of thing. So those larger agencies are going to be able to withstand a lot of what we're going to see in 2022 in relationship to some of the payment changes. Your referral sources, of course, are going to, the best way to get referrals is from the hospital, of course. And Medicare has, for a very long time, tried to get home care to seek referrals, and they would rather see referrals coming from hospitals. A number of years ago, before many of you probably were in the business prior to 1980, hospitalizations were required prior to admissions to home health. And there was a period where they've talked about it, and we haven't been subject to that restriction as home care agencies. But I can tell you that some of the things that are happening right now are going to kind of force us to seek out more hospitalization, more post-acute care patients rather than community referrals. And that's exactly what CMS would like us to do. They want patients that are coming home with more acute conditions and that type of thing. So you're going to want to be looking for hospital discharges. So your marketing efforts are going to have to change. And many of the smaller agencies, I'm aware, have mostly community referrals, not so much the hospital discharges. So that's going to be a very big impact. We will see a lot of wound care, and as David said, there's going to be an increase in dollars for wound care type patients. And we will see a lot of that as they come from the institutions. So getting those institutional referrals will be most often sought after by the home care agencies. As far as endocrine, of course, the one thing that we think about are the diabetics, and with so many of our patients being diabetic, that we see now, even as community referrals, we're going to be seeing more, I believe, more new diabetics and more of those that have exacerbated in the condition. So the endocrine, seeking referrals from endocrinologists probably would not be a bad idea for your marketing staff. So as you can see and look at those numbers that David went over, you'll see that retraining and redirecting your marketing staff is going to be a really good idea as we go into 2022. The surgical aftercare, I think, is really interesting because right now I've been reading quite a bit in the last few days about many of the hospitals are not doing elective surgeries right now, and probably into 2022. We have the outbreak again of the Delta virus and the increase in COVID. So many of the hospitals are not doing a lot of at least elective surgery. So that probably will not enter into the mix as much as it could have had we not have the pandemic still pushing against us and the care of our patients. So the complex care, as David mentioned, is going to be, we're going to be seeing probably less of that because the payment isn't there. And be really careful with that because, you know, CMS is still charging us with behavioral types of claims that we're changing our behavior. And since we've been taking so much complex care in the past, they're going to be looking to see if that changes in the near future, and particularly with the 2022 payment system. So we want to make sure that we have a good mix, and those complex care patients are still going to need care. So we have to make sure that we're providing all the care that everyone needs, and at the same time maintaining the health of our agencies. One of the things I wanted to bring up too here is that I believe that we really have to focus a lot on assessing our intake process. The intake process is going to have to be very solid in your organizations. I believe the intake departments are going to have to get a lot more information about your patients prior to sending a nurse or therapist out to do their start of care assessments. And we're going to have to make sure that we're falling into an area where we are going to be able to have enough income with particular patients in order to keep our agency going. So getting as much information on the front end from intake is going to be really, really important so that we're not accepting patients that we know are going to cause problems financially within the organization. So it's important that your intake staff understand the impact of all of this information that we're giving you today, and that they're aware of what types of patients they can and cannot take. I think your intake staff has to be a very, very active, an important part of your QAPI program as we look at these changes, because QAPI is going to have to, the QAPI committee is going to have to take a look at what you're going to do to manage all the referrals that you have coming into your organization. And again, not taking patients that are going to challenge your bottom line within your organization. David mentioned LUPA. LUPA has been a problem in the past year, and particularly because of the pandemic. But we're going to have to be very careful about missed visits and making sure that that LUPA status is as low as we can possibly get it. That has caused financial difficulty in many, many agencies over the past year. And I don't see with what's going on now that that's going to be a whole lot different next year in 2022. So it's something that, again, that's something QAPI needs to look at. Take a look at your LUPA rates within your organizations and make sure that you are doing the very best you can to avoid those missed visits. Make sure you have, I know there's a challenge with getting staff right now. If you're an Axxess agency, you have a bonus there because we have Axxess Care that's available that can provide care when you're short-staffed within your organization. So that's going to be the challenge, is having enough staff, making sure that we don't fall into LUPA rates that we can't control. Next slide, David. So as far as coding is concerned, we're going to follow the same principles of coding, but you want to make sure what we found with PDGM this year is that the coding was not matching up with the final claim. So we want to make sure that your coders understand the importance of making those codes match up with your HIPS code, and that you continue to follow the same principles of coding. We have new coding books coming out very soon, so any of the updates will be in there, and I would expect that they will include some, I have not seen the new coding books, but I expect they'll include some PDGM advice in there and some tips on how to avoid problems with your coding related to PDGM. We are going to need, and you're going to want to make sure that you have updates in your resources for training with your staff and OASIS-D. OASIS-E is scheduled to come out. I don't know that it'll come out in January next year, but particularly OASIS-D, you want to make sure, as David mentioned, the functional part of the assessment is going to be really, really important. So getting your therapist and your nurse to do the assessment either together or certainly coordinate care as soon as that assessment's done by each staff member will be really, really important. So you want to make sure that, again, your assessment information is accurate as can be. And looking at value-based purchasing, we want to see that the outcomes of the patients are as good as we can possibly get them. So the only way you can do that is to make sure you have your staff trained in OASIS at the front end at intake, and then also at discharge in the back end. So your referral information, again, making sure that your intake staff understand what all they need to be getting as far as referral information, that your face-to-face has enough information so that you can get accurate coding. Again, the face-to-face isn't necessarily going to match exactly what you have going on in the home, but it certainly should be an indicator of where you're going with that referral. And again, that the coding is as close to accurate as you can possibly get when you do your no pay wraps on the front end. So again, value-based purchasing, we probably will be doing many webinars on value-based purchasing in the future. That's a very complex situation for those states that have not been able to take part in value-based purchasing. And as David mentioned, all of our states will now be part of value-based purchasing, and some will be winners and some will be losers, just as David said. So it's going to change the way we look at patients, change the way we care for patients, change the way we hang on to our patients. I mean, I've seen some agencies where they recert time and time and time again. I see agencies where they discharge patients and restart them after a couple weeks. Someone at some point told them that that was a good thing to do, and it never has been. And with value-based purchasing, we'll see that that is something that we absolutely won't be doing any longer. So I think that all in all, we have some work to do as we go into 2022. And with the next slide, we're going to see that we have some other changes that are going on. One of them that I think is really very important is that occupational therapist is going to be able to be doing all of our, not all of our assessments, but assessments without needing nursing or therapy in there, as long as occupational therapy services are ordered by the physician. And so that will continue from the 2021 exceptions that we had due to COVID. So the LUPA rates will be for occupational therapy will be the same because we don't have any data on that for the past. They'll be the same as they use for physical therapy. So that's important to understand. The other thing that's changing that I'm a little bit concerned about is that the supervisory visits for home health aides, they will still continue to accept supervisory visits using technology. Now, if you're using some type of video with that, I'm not as concerned, but I would hope that agencies would continue to do on-site visits with the patient regarding supervision, and also on-site visits with their home health aides, because I just think that that needs to be done. And I think we need to have a hands-on, eyes-on approach with aide supervision on an ongoing basis. So I would encourage you to continue to do that, even though CMS had made an exception. Now, I did read that the surveyors are going to be looking very closely, and that you're going to have a really good reason for why you did not do an on-site visit with the 14-day supervisory visit. So make sure that you have a way to document that in your clinical record. Sequestration is going to continue in 2022, or is going to be added. 2% cut in Medicare reimbursement will be levied again against us. They suspended that a couple times, but they're going to put that back into place if we don't say something. So that's one of the things that I'm certainly hoping everyone, I would recommend that you would make comments on with CMS. So again, CMS isn't going to alter that 4.36 behavioral adjustment. So watch what you're doing as far as your referrals and your coding, making sure that we are continue to function the way we have in the past. Make corrections to things that you think that would be good to make corrections in, but make sure that your behavior doesn't change so much that you start getting U-picks and reviews that you might not expect. So on the next slide, David, we see that we have comments that are due by August 27th of 2021. So that's coming up in just a couple weeks. I've given you the information from CMS that you can take a look at and see how you can address these comments. They're not taking fax comments any longer, so we're going to want to make sure that we do that in email. And I believe the next slide shows us how to contact CMS and electronically. I've given you the website for that, but make sure that you get those in, that they're detailed enough. And again, I would encourage you to thank CMS for the opportunity to make the comments in the front end. Don't start making negative comments right away when you submit these. It's interesting though, when we get when we actually get the final rule out, many times CMS will address the comments, the specific comments in the final rules. And so you probably want to stay tuned and see if yours is actually mentioned. They do read all of the comments. So be assured that if you have something to say, they will take that under consideration. So on the next slide, I believe, is probably our ending slide. And I want to thank everyone for taking time to listen to David and I today, and getting information on what's upcoming in 2022. And I would encourage you to seek out information from Axxess if you have any questions about this webinar or any of the webinars that we do. and look forward to working with all of you in the very near future. Thanks again for attending today.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on software advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.